Bismillahirrahmanirrahim. Today, we are going to demonstrate a case presentation of Hydatid Cyst of the liver. A 46-year-old male patient complaining of asthma-like symptoms with no previous history of any medical or surgical illness. He went to seek medical advice to a physician, and a chest X-ray was done. The only abnormality in the chest X-ray was raised right cupula of the diaphragm, as you can see here. This is the report, raised right cupula of the diaphragm for Persian fixation. So the patient was sent to the surgery department, and the CT was done, a triphasic CT. As you can see here, there's a cyst in the posterior part of the right lobe of the liver, and another cyst in the left lobe. The cyst in the right lobe is multilocular, but the cyst in the left lobe is unilocular. This is a coronal reconstruction of the CT scan showing that the cyst in the right lobe occupied the superior part and superior segments. Thus, this is why the right cupula of the diaphragm is elevated. The CT scan report says that a large multiloculated, well-defined cyst, measuring about 10 by 8 by 8 centimeter dimension, multilocular, as we said, with multiple daughter cysts, with no enhancement after IV contrast injection, and another cyst in the left lobe, measuring about 8 by 8, 9 by 8 and a half by 8 centimeter dimension, and it was a unilocular cyst. So the patient was sent to a ELISA test for Hydatid antibodies, and it was positive.
Furthermore, we investigated our patient. We decided to proceed into surgery, and then this is the left side of the patient, and this is the right side of the patient. And we started with the cyst on the left side of the patient, and we started aspiration of the fluid inside the cyst. But we found bile came out, which is not normally to found, because Hydatid cyst fluid is characteristic to be clear as water, odorless, and colorless. Then later we injected the hypertonic saline, which is the most commonly used scolecidal agent in this case, and we opened the cyst, as we can hear, and the yellow color is the bile. Then we did partial excision of the cyst and trying to remove the content. Because I said earlier there was a bile, we tried to identify or rule out the presence of biliary fistula. So actually what we did is transcystic injection of saline, and then we dragged the orifice to close directly the fistula. And this is the contact of the cyst with its scoliosis. And now we are moving to the cyst on the right side. This is the bare area of the liver after cutting the triangle diaphragm. As we can see, the liver capsule is intact and smooth and completely normal. But the surprise was we found this indentation in the liver parenchyma. So what was that? As you can see again, the capsule is completely intact. So the surprise was we found the cyst bulging from the diaphragm, stretching its layer. So it's coming from upward, not from the liver. As we can see, it is the cyst and this, the layers of the diaphragm. At this moment, we stopped for a second and we called for a cardiothoracic surgeon consultation, and we informed the anesthesiologist about maybe the probability of needing intercostal tube, because we are dealing with the diaphragm and maybe there is a pleural injury, so better to take care of that during trial of excision of the cyst. But lucky us and lucky the patient, we found it uncomplicated because it didn't invade the pleura, and this is after opening of the cyst, we can see the scoliosis inside. So here is after excision of the cyst, this is the pleura at the bed of the diaphragm, and this is the diaphragm layers. And this is the chest X-ray preoperatively. As I mentioned, there is elevated right cupula of diaphragm, and here back to normal with residual air, which is very normal postoperatively and resolved spontaneously. So what is the explanation of such an interesting, unatypical presentation of this case?
The explanation was it was a transdiaphragmatic thoracic migration of the hydatid cyst of the liver. The transdiaphragmatic migration to the thoracic cavity occurs in 0.6 to 16% of cases of hydatid cyst of the liver.
So as I mentioned, because it's uncommon presentation, the reported mortality rates vary so much in a big range from 5.6% to 50 to 43.7%.
The transdiaphragmatic migration, which occurs from the posterior segments of the right lobe of the liver, has been reported to be a common complication, and is probably due to its proximity of this area to the diaphragm.
Also, the prayer area of the liver, we all know it has a very huge clinical significance in our field because it's a site, or a very common site by far, in transferring intra-abdominal infection to intrathoracic cavity, and this is by far the most common route, as I mentioned.
This is due to lack of the peritoneal covering on these particular areas, resulting in decreased resistance to cyst growth.
So transdiaphragmatic migration can vary so much from just simple adhesion to the diaphragm to even horrible complication as rupture into the pleura, or even causing chronic bronchial fistula. And this is CT image showing a cyst near the right coupler of the diaphragm. Lucky this patient also didn't invade the pleura, but we will see it. Next picture, very interesting. Here I have to mention that the partial classification is a septum of the cyst. It doesn't denote resolution of the condition. It just denotes part of the cyst is dead, which is important to keep in mind.
This is another CT scan from the literature. This line is the diaphragm, and those are the cysts which have been migrated through the diaphragm and present in the thoracic cavity. This is another CT captured at the time of migration or budding, as you can see here, the cysts leaving the liver and appearing as a thoracic nodule. Thank you.
Thank you.